So we will go ahead and get started, and want to welcome everyone today. And we have a great topic, and actually the topic today was selected based on some feedback from some evaluations that we had received on other programs. That chronic care management was a topic that individuals hope to listen to on our education webinars and just generally learn more about. So before we get started though, I'll go over a few logistics. I want to thank Allie Orwig with the Indiana Rural Health Association for helping support Zoom, and also Joyce Fillenworth and David Conrad with the State Office of Rural Health for all their support and funding to be able to provide the free education webinars that we're able to through the MB-QIP program. So today we will discuss care management. We have actually a nationally recognized speaker presenting for us today, Lisa Pando, and she has also worked with some of our Indiana hospitals in building swing bed programs in particular. Lisa does work along with Kerry Dunning, and if you've joined any of our swing bed webinars, Kerry Dunning is the consultant that we work with to provide ongoing education for swing bed programs. So to kind of introduce Lisa just a little more, Lisa has over 30 years of experience in hands-on clinical and nursing administration roles, including 11 years as a director of nursing for a 167-bed nursing facility. She specializes in development of policies and procedures, medical necessity documentation, and QAPI program. And Lisa has a really good understanding of federal rules and regulations as well as Joint Commission standards. She's helped answer some questions related to both of those for us. And then for the last 13 years, she has served as a certified legal nurse consultant to attorneys on in-depth medical record reviews, including understanding legal aspects for developing and monitoring medical records for case review. And as I said before, Lisa has presented several times on a national level and well known for her expertise. So at this time, Lisa, I will mute my line and turn it over to you. We will also, if you would like to ask questions, please feel free to unmute your line or chat in questions, and I will monitor chat and we'll make sure that your questions are addressed. So Lisa, I'll hand it over to you.
Great, thank you, Becky, and thank you, Allie. Today's presentation is going to be on chronic care management. What, why, who, and how. I did a lot of research on this. It's a topic I did know about, but there's been a lot of changes, and we're going to go over those throughout the presentation. So like Becky has already notified you that please, ask questions. If you don't have questions during the presentation, usually right after it's done, you say, oh, darn, I should have asked X, Y, or Z. Please feel free to email me or Becky, and I can get back to you as soon as possible regarding answers to your questions. Just a little housekeeping here. Neither myself nor Kerry Dunning LLC has any proprietary interest in any product, instrument, device, service, or material discussed during this learning event. There I am. You can throw darts, whatever you need to do, but that's my background. A couple learning objectives. Number one, we're going to try to understand how chronic care management programming can reduce or eliminate negative patient outcomes. Also, to identify key components for a chronic care management program, and also discuss key steps to forming a chronic care management program within a physician practice. So what is it? What is this chronic care management that is on the horizon and we're hearing more and more about? It's actually a program that recognizes value that primary care is bringing to healthcare. Throughout the presentation, I'm going to probably use CCM and interchange that with chronic care management, so it does mean the same thing. But in 2015, Medicare began to pay for this management service. Now, of course, nothing comes free from Medicare. So there are guidelines, there are restrictions, there are rules that you have to follow for you to be able to bill for this service. But finally, all of that time that we spend outside of an office visit with patients is being recognized that this is important and this has value for patient healthcare. So improvements to the CCM program were made in 2017. Now remember, in 2015 is when Medicare started to pay for the programming. And in 2017, they've already recognized increased payments to providers, and they expanded the programming by adding additional CPT codes. Those of you that are not familiar with billing, a CPT code is something that identifies what's being done at the time of a visit, and those codes relate to the payment itself. So already within 2 years, the value of the program has been recognized. And it started with just one CPT code, and we'll get into that later on in the presentation. But when they started paying for the program, there was one. Now there are 6. So the value and the growth of the program are increasing. So it is kind of an interesting subject, and hopefully we'll all be able to take advantage of the CCM programming. So what is it focused on? It's focused on identifying your high-risk population, those residents that are at high risk for hospitalization, for decline over in between office visits, basically. And it's using skilled staff, your nurses, your office team, to manage care, to reduce those hospitalizations and to reduce emergency department visits. You know, as healthcare transitions from, fee-for-service model to a value-based payment, billing for this service makes it possible for physicians to be paid for their time and effort in managing those chronic conditions. And you'll see in a little bit, we're going to go over what those chronic conditions are and what Medicare has deemed the chronic conditions that are high risk. So your ideal care management programs are team-based, means everybody knows what's going on with that patient, patient-centered, that we're not just doing the same thing for every patient, that we take the patient and we look at them and we progress in that way. And it's dedicated to population management as opposed to disease management. And in a little bit, we're going to go through some slides and you'll be able to, this will make a little more sense in just a few more slides for you. So the overview. What are you giving? What is the patient receiving with chronic care management? Additional support and services, and that's a positive outcome for the patient. They're going to get their chronic conditions managed effectively, and that's a positive for the patient. Coordinated care leads to better health. That's a positive outcome for the patient. And decreased overall healthcare costs. Not only is that a benefit for the patient, but CMS also benefits from that. That's decreased overall costs for them, and that's really the goal. Even though they're paying for more time throughout the month when a patient is on chronic care management, overall, a decreased hospitalization costs a lot less than a 20-minute phone call to a patient. So what is it exactly? It's care coordination outside of the regular office visit for patients with, and here's a key piece, 2 or more chronic conditions. So they have to have at least 2 chronic conditions for them to even be considered for this program. The conditions are expected to last at least 12 months or more, or until the death of the patient. So it has to be something that's not going to clear up, overnight or within 3-4 weeks or months. It has to be at least a 12-month duration. And also these chronic conditions places the patient at significant risk of death, acute exacerbation, or decompensation or functional decline. So most of the patients with these chronic conditions are at significant risk of death, acute exacerbation, or decompensation. You know, the first one that came to mind when I was writing the webinar is COPD. I mean, COPD just kind of falls right up there with, in my opinion, number one, because it's just one of those things that is just going to exacerbate on occasion, especially if meds aren't taken, or, you know, if the patient runs out of meds, like a lot of times they do. So once we identify those residents, then we move on to the next steps. So planning is really, really an important issue that must be addressed. You must plan before you even consider a chronic care management program. So this slide kind of identifies the top 21. So if you hear me talk about the 21 during the rest of this webinar, it's these are the conditions that CMS or Medicare has identified as the top. But they do not put a cap on what exactly is considered a chronic condition. So although these are the top conditions that they see and would like addressed in a chronic care management program, it is not limited to just these 21. Okay, I kind of just said that. CMS has not specified or otherwise limited the eligible chronic conditions that meet this definition. So the 21 are the top, but again, they are not limited to just those. But CMS does expect that physicians will focus on the eligible patients. This is a Medicare Part B program, that they are going to focus on the patients with the higher acuity and the higher risk. So even though they say 2 or more chronic conditions will qualify a patient into the program, they're hoping that patients with 4 or more chronic conditions will benefit more from the CCM services. Again, it's planning and doing your homework on your population and your practice to make sure that you're capturing as many patients as possible. I'm sorry, I keep using the word resident. I do a lot of work in long-term care facilities, and I currently am in one right now assisting, and that's why resident keeps coming out, but I mean patients. I know I'm talking to some hospital staff, so I apologize for that. Okay, so let's take a look at this map, and there's tons of data out there, tons of it in regards to chronic care management. But if you look right here in the center, I kind of identified Indiana specifically, and this map shows you the in regards to drug and substance abuse. Now, drug and substance abuse was one of those 21 that we looked at just a little bit ago. And as you can see, the state prevalence is 3.33%. The national average is 3.5%. So you're kind of midway there, Indiana. You may have some residents that have drug and substance abuse issues as well as another chronic condition. But what you want to do is you want to plan for those residents with the highest prevalence. So with that being said, let's jump to my favorite, COPD. If you look at this, you're way up there, you're dark red. So you're up here at the top where it says COPD prevalence, where this little arrow is. And the state prevalence is 14.26%. So that's pretty high, when the national average is 11.47%. So you're well above the national average with residents who have COPD. Okay. And then again, we have depression. So how many residents with COPD have depression? Probably quite a few. So there's right off the bat is your 2 chronic conditions that would place this patient into a CCM program. Again, if you look at the center of the map, here's Indiana. and you're bright red, so you're way up there. And the state prevalence for depression is 21.09%. That's really high. National average is 18.4%. So again, you're a little bit above the state, the national average. But here's a condition that, you know, many, especially elderly patients have, depression, depending on their other chronic conditions. So, you know, with that being said, you probably want to pull up your diagnoses first and look at your residents or your patients that have the highest prevalence. And like I said, there's plenty of data on the CMS website. I also referenced it at the end, so you can just click on it and pull up. Actually, they have all 21 of the chronic conditions that they deem are the top 21. And they have the map and they have the, you know, the prevalence and everything. So it is pretty interesting. And this is 2018 data. So hopefully we're going to be seeing some new data soon, but this is the last time that they kind of took a really close look at it. All right, so when we look at per capita spending, that's the national spending per person with the diagnosis. And they started looking at it in 2007, and here's 2018. So I listed those two in columns, but remember they didn't start paying for it until 2015. So that was kind of interesting to me when I started looking at all these numbers. So if we look at drug and substance abuse, we have 24,491, and in 2018, 24,958. So not that much difference in spending per capita. It's only about 2%. But if you go down here to hyperlipidemia, in 2007, they were spending 9,400 something per patient. In 2018, we're looking at 14,327 per patient, per capita spending. Hyperlipidemia is up 52% since 2007 in spending. So it's probably, it was eye-opening to me as to why this program is needed. And you know, we do have a country that has higher incidence of obesity in the later years. So you can see where the spending is changing and how it's going up, even with hypertension. I mean, hypertension was 11,000 plus per patient. And in 2018, we're at 14,486 per patient, per spending, national spending. So that's quite a bit also. The other one that kind of interests me was Alzheimer's. Alzheimer's disease went up 48% from 2007. And why is that? Because a lot more Alzheimer's patients are at home with their families. They're not putting them into nursing homes. They're keeping them out of the nursing home. But in keeping them out of the nursing home, who's monitoring their chronic conditions? Well, when the person gets sick, then the family calls. You know, my sister takes care of my elderly mom. We're blessed she doesn't have extensive Alzheimer's, but she does have some short-term, long-term memory loss. And with her, everything is a crisis because she doesn't want to bother my sister. So she doesn't tell my sister anything. So if we're looking at Alzheimer's disease as one of her chronic conditions, we've got to get her to start talking, because that's part of the reason why she's wound up, you know, with hospital stays, because she won't tell my sister that she's having an issue. So, and that is with a lot of the elderly these days, you know, they don't want to bother anybody. It's, you know, they want to keep things private. They don't want people to know. But then when they get to the doctor's office, you know, they've got this plethora of complaints that family members don't know anything about. So when we look at the aging process and we look at the increase in the spending, CMS had to do something. And I think they're on the right track with chronic care management, and hopefully they'll stay on the right track. So when we rank these 21 common conditions, look what's number 1 and number 2, hypertension and hyperlipidemia, in that order. So how many patients with hypertension have hyperlipidemia? Quite a high amount. So there's 2 chronic conditions right there. And then it goes on. Arthritis is number 3, diabetes number 4, ischemic heart disease 5, and chronic kidney disease 6. Now, if you look at some of your residents or some of your patients, some of them have all of these, all of them. So that's where you need to start. You need to start with looking at your patient population. You need to look at the common chronic conditions, and you need to rank them in the highest ranking of the high risk. And that would be probably more than 2. Even though 2 qualify, you want to make sure that, you know, you're getting the biggest bang for your buck, for lack of a better term. Okay. So now, like I said, there's so much data out there. It was mind-boggling to me. So I just took a couple of things out. And it was funny because when I started classifying them, I was like, oh my gosh, look at this. So chronic conditions among fee-for-service beneficiaries. 57% had hypertension, 48% had hyperlipidemia. So then I moved on to chronic conditions by age. 65 years and older, hypertension was number 1 at 60%, with hyperlipidemia following at 50%. And even those less than 65, hypertension, hyperlipidemia. Gender, same thing, hypertension, hyperlipidemia. So look how many patients, how many of them in different categories still have hypertension and then hyperlipidemia, number 1 and number 2. So that was kind of interesting to me. I kind of like data sometimes because it kind of tells us a story that we may not see right away. But yeah, this was pretty interesting that the 3 that I pulled out all had hypertension followed by hyperlipidemia. So we can probably acknowledge that most of our patients who are taking hypertensive meds have some other chronic condition associated with them. Okay, so why would we even bother to do a chronic care management program? And the reason is patients are going to gain a team. Now, I know we said this before, but it's important that these are some of the key components of this program, that the patients gain a team, not just a doctor. They don't just go in to see the doctor. They're going to have a team of health professionals that are going to keep them on track. And that's the key point of the program also, is to keep them on track, make sure that they're in good health care, and make sure that they don't have to run to the hospital for a crisis mode like my mom does all the time. They're also going to get comprehensive care planning. This is also a key point. So if it's something you can't be bothered with doing, then CCM program is not for you or your practice or your physicians that you work with. The comprehensive care plan and the care planning and the updating of that care plan is some of the most important issues and key components of the program. Patients are going to receive support in between scheduled office visits. So they're going to get additional support. They're going to get additional help in their minds. So it's not an office visit. It can be. I mean, if they have to come in, they can come in, of course. But the support for the program and the additional reimbursement comes from that additional support in between that office visits. It's going to improve care coordination between providers because only one provider of the resident or the patient can bill for CCM services. So if they have a kidney doctor and a cardiologist and a gynecologist and an internist and a gastroenterologist, and they have a primary care doctor, the primary care doctor will put the patient into the chronic care management program, then would have to alert all the other providers that the patient is under a chronic care management program and that they are the coordinator of care, basically. So the cardiologist cannot bill for CCM services, the gynecologist can't, the gastroenterologist can't. Only the primary care doctor who writes the first care plan and gets the verbal consent from the resident is the only person who can bill for that. Now, we're going to get into more specifics on that as we get through the rest of these slides here. Also, person-centered care, that goes right along with the care plan. So it's more focused on the resident. They feel like it's more focused. They feel like they have more help, even though it's the same amount probably that they've been getting, but now the doctor can pay for it, or the doctor's practice can get paid for it.
Lisa, this is Becky. A question came in as far as for critical access hospitals, do you have some suggestions and innovative ways to assist a patient in information being transferred between the physician practice and the critical access hospital?
Well, would it be a physician that's working for the hospital? See, the billing comes into question because critical access hospitals can bill professional services in two different ways. Either they bill the professional services for the physician, or the physician bills his own. So it would depend on the physician themselves. And if you have a good working relationship with that physician, then again, it's the planning that's going to make it successful for that coordination of care. Because a lot of times these patients that have multiple chronic conditions, they have multiple physicians. So once that care plan is established, that care plan would have to be shared with every physician that patient has, sorry. So the critical access hospital, the hospital itself would have that information, hopefully on file for the patient. But the physician would have to notify the hospital that he is starting the CCM program. So it has to start under a physician, because that's how it's billed. And even though a non-physician practitioner can bill for the services, they still have to be under a physician. So like what was I come up with? A case manager, an independent case manager that just, is hired by a family to monitor the care. They're not working under a physician, so they cannot bill for CCM services. So it has to start with a physician. And if the physician has a nurse practitioner or an NP in their practice, then the nurse practitioner can see the patient and still bill for physician services as they bill for now. But the other information that's obtained, like contacting the resident every month to make sure they're okay with their pills, to see if they need an additional script because maybe they had an exacerbation and didn't come to the hospital, but now they need more breathing treatments. So, ordering that over the phone and just, taking that information over the phone and monitoring the patient that way without the patient winding up in the emergency room, that is also billed. And again, that's where those CPT codes come in for the different things that are being billed out. And we're going to get to that also. But the critical access hospital would have to have, and the same for the rural health clinics, good rapport with the physicians who are going to do the chronic care management program. And it is a program. They can't just say, okay, I'm going to bill for this month and use this CPT code. That's not the way it works. There are those key pieces of the program that must be done, and we're going to get to that. So once all those key pieces are done, then the physician is able to bill for those services. So again, you can't just start this program and say, okay, I'm going to do this, I'm going to sign these patients up, and we're going to do it, and expect that it's going to be worthwhile to both the patients and the physician. You have to plan. There has to be some planning involved in this. You can't just jump right in and say, we're doing this and we're going to bill. You have to have all your ducks in a row, or it's not going to work. And I say that, and I'm not trying to deter you from starting the program. I'm just saying, you have to think things through. You have to gather your data. You have to make sure that this is going to be beneficial to you. So I know I haven't answered that question fully yet, but it's because there's more coming towards the end of the presentation that may clarify that a little bit more. And I also have the CMS booklet on critical access hospitals and the billing, and that's in the references at the end also, which kind of describes about the billing for practitioners and which way you decide if it's the outpatient method 1, method 2, the standard outpatient services, because this is an outpatient service. So again, you have to work with your physicians on this. Okay, so initiating the services, the provider, that is the physician, is required to complete an initial face-to-face visit for all new patients that are enrolled in the program and for patients that are not seen within 1 year of the start of the CCM. So you can't just call them and say, hey, can you sign this consent form? We're going to put you in this program. We're going to take care of you this way. They have to come in. So the face-to-face visit can be alongside an annual wellness visit, an IPPE, preventive physical exam, transitional care management, or other qualifying face-to-face. So if the patient is coming in for their annual wellness visit, okay, that is something that's billed completely separate from the CCM. But again, you have to make sure that your records are very clear when you're billing for these things. So you can bill for your annual wellness visit. And then you would say you started to discuss with the resident at, a certain time, and that discussion ended at another certain time, say noon to 12:30, you spoke with the resident in regards to CCM. So that wouldn't be billed with the annual wellness visit, but your initial CCM visit could be billed separately because the physician would be speaking to the patient about specifically CCM. And with that would be the comprehensive care plan, the discussion, the consent form, just to make sure all that documentation is in place. So they could bill for 2 separate visits if it's clearly written and it's not a double dip. Okay, you don't want to be doing that double dip because Medicare will jump all over you, and the last thing you want is additional documentation requests that you're being audited. Okay, so very important, that initial face-to-face visit in regards to the chronic care management. Okay, so getting started, in everything that I've come across, everything that I've read, you should start with identifying your Medicare Part B patients, because this is a Medicare Part B program. Then from there, you want to look at those patients that have 2 or more chronic conditions. Again, that's expected to last at least 12 months or until the death of the patient. Okay. Then you want to prioritize those patients at highest risk of hospitalization or have recently been or are regularly seen in the emergency room. Those are your frequent flyers. You know who they are already, okay? We know who those patients are. They don't monitor their meds. They don't monitor their doctor visits. They don't routinely get to where they need to be for physicals, et cetera, et cetera. So we do kind of have an idea. And I'm sure all of you listening probably have an idea also. Oh, certain patients come to mind. Yes, they do, because it's just the way it goes. There are those patients. So you also want to start with patients that regularly call into the clinic to manage symptoms or with medical questions. Now that's also a key, because we don't get paid for that right now. We answer calls all the time. You don't get paid for it because you're just picking up a phone call, answering that patient's question, and move on with it. So that's a big key piece. It doesn't pay a whole lot. As we get to the CPT codes, we'll talk about that, but it pays enough that it's covering your time, and it's covering the time of the key player in the office that's going to be the care coordinator. Because once the doc sees that patient for that initial face-to-face, the doctor may not have to see them again for a long time if they're monitored. So, you know, there's good points, but there's also, like I said, and I know I keep saying it, I can't, you know, keep me down with this, but you have to plan before you start, okay? Okay, so again, identify patients that may be most likely to benefit from care management based on the number of specialists involved in their care. Now that's another piece. You know, if they have the gynecologist, gastroenterologist, internist, et cetera, et cetera, et cetera, there's a lot of people, a lot of docs, a lot of medical professionals involved in their care. And a lot of times one hand doesn't know what the other hand is doing. So that's where that care plan comes into play. And the care plan is shared with those other physicians. And that is one of the key parts of this program that you cannot overlook. You must have a coordinated care plan. Okay, another thing that has to be discussed with the patients is payment. Because it is a Medicare Part B program, okay, they will be responsible for some payment, unless of course they are duly eligible. So if they're duly eligible, Medicare and Medicaid, more than likely they won't have any cost share with it at all, okay? But they have to be told they might, because if it's a managed Medicaid or if it's a managed Medicare, it may not be covered fully. So they may have some cost share with that. And that's always a problem for patients because, hey, why should I have to pay any money for this program when I can just go to the emergency room and get paid? So it has to be explained fully. You need to identify those patients that it's not going to cost them anything because those are the ones that are going to say, sign me up. I'm going to get more help and more care and more support. I'm in. It's not going to cost me anything. So again, that's another thing at the top of your list that you want to identify. Another very important piece is the consent. Now, all of the CMS documentation says obtain verbal or written consent. I would lean towards the written consent of the patient because when they have to sign their name, they pay a little more attention to what you're saying. So verbal consent is allowed, but it has to be documented again in the medical record to say verbal consent obtained from resident in regards to the chronic care management programming, something to that effect. Again, I would lean towards written consent, but that's just me. If verbal consent works for your practice or your residents' patients, then by all means, whatever works for you. And another key piece is develop that comprehensive care plan. Now, I say in the electronic health record because that's just going to make your life easier. But I know some places they like to use paper still, and that's fine. But again, every encounter that is updated and written into this comprehensive care plan, the updates must be in there, dated, timed, and keeping it constant and up to date. If it's in the electronic health record, it's much easier. But again, whatever works for your practice, but it must be in there because that is a key component. Here's your other key component, your designated care team member. And the reason why I say that is a key component is there's some staff that are very type A and they can keep everything in order and they know times and dates and what's going on. And then you have some staff members that come to work because they need a paycheck and what they get through during the day, they get through during the day. Hopefully you have the first care team member who is going to be on this program. And that person will be responsible to make patient contacts, schedule appointments, make sure that any updated care plans are sent on to the other providers, regularly talk to these residents who are on the program, you know, whether it's weekly, monthly, whatever it happens to be, but that care team member that knows, oh, you know, Mrs. So-and-so said she had a stuffy nose last week. Maybe I better call her this week and see how she is this week. You need someone who's forward thinking, but yet type A, that can keep all your notes and things in order, because that's how you will get paid. And once we get to those slides, you'll see what I'm talking about. It's all timed. So you want to make sure that you're capturing all of that time. And if you're not, then the program doesn't work, because you're not going to be able to bill for services that aren't documented. Okay, so there's another piece, and I've read some conflicting reports about it. And you have to be able to provide patients a way to contact the physician practice, not the physician specifically, but the physician practice at any time to address urgent care management needs. Now, some documentation says that is 24/7 access. Some documentation says that is not adequate for answering service to take the message and then the doctor to call back in the morning. It must be 24/7 care. So does that mean having a specialized phone number and having a variety of care team members that carry the phone on call, so that if a resident does call, they can get the help that they need? But it does say 24/7, and most of the documentation says answering service is not acceptable to fulfill that requirement. So depending on your answering service and depending on how you decide to progress with that key component, is another thing you need to plan for. You know, a phone might be it, but you know, a separate phone with a separate phone number so that they're not calling the practice. And this would only be for those patients who are on your program, not for every single patient in the doctor's practice. So again, you got to think a little bit about this before you jump in. So your care team member should be very detailed oriented and able to document everything. So documentation, 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 key piece. All right, so we've already talked about a lot of these things. Verbal or written consent from the patient for them to receive the services. Informing them of applicable cost sharing. You have to tell them if they're only Medicare Part B and they don't have any supplements that they may have to pay a piece of this. They can stop receiving the services at any time, but they have to let you know. So again, you have to document resident called on such and such a day at such and such a time and no longer wants to be part of this programming. And that's it. And they have to acknowledge back to you that only one practitioner can provide the services during a calendar month. So if they want to revoke services and you've already processed payment for that month because they've been in the office, they can't go to another provider that month and sign up for CCM services with somebody else and that person bill. So they have to, that has to be understood in advance. Okay. If they don't want to be in the program, that's fine. They don't have to be. But you should encourage them and you should have a lot of information for them to explain to them why they want to do this. So we need to convince them that they want to do it because it is going to be beneficial for everyone. Comprehensive care plan. Again, there's a lot of information out there. There's all kinds of checklists for documentation. I believe I put those into the references. If you're looking for something and can't find it, please email me afterwards because I do have a lot of things. I believed I put them all into the references, but if I miss something, just email me and I'll be happy to send it along. The comprehensive care plan, there are templates out there. I've seen a gazillion templates about comprehensive care plan. So that should not be difficult for you when you're starting to think through this and decide how you're going to do it. But there are pieces of information that need to be shared with, like I said, all the other healthcare providers. It has to be maintained and updated. So if something changes throughout the month, that key team player that you're going to choose, which could be a nurse in the office, it doesn't need to be a nurse practitioner or the physician. It can be a nurse working in the physician's office. It has to be updated. So if there's changes that happen, that person needs to remember to go into the care plan and update it. And again, you want it to be person-centered. So it has to be based on goals, has to be based on the physical, mental, cognitive, psychosocial, has to contain goals, interventions, assessments, same thing as care plans in the hospital have to. But it has to be patient-centered. So if the person has hypertension and that's one of your chronic conditions, you want to make sure that you're getting into that, you know, how often their blood pressure needs to be checked, what their body mass index is, their resting heart rate, how much are they sleeping, those types of questions. So it has to be very, very, like it says, comprehensive. It also should contain a problem list. Their treatment goals we already just talked about, cognitive functional assessments, very in-depth. Again, there's lots of information out there on comprehensive care plans for CCM. So find the one that works for you and make sure you have all of these pieces in there. Make sure that that's in place. If it has to be built into your electronic health record, then by all means, look at that first and make sure it's as in-depth as possible, and get that built before you even decide to start this program. So billing, I know I'm running a little behind here, but for billing, what counts for billing? Visits by phone or FaceTime or Kindle Fire or whatever heck the other ones are, and secure email. There, you can set up a specialized secure email so patients can email you directly to that email account and ask their questions that way. Some people just don't like to talk on the phone, and they'd rather send emails. So if you have all those pieces set up, that will help everybody, regardless of what their preferences are, then you're on the right track. We talked about the sharing of the patient health information with other providers. Managing care transitions. If you hear Mrs. So-and-so was in the hospital because she tripped and fell and had to have some stitches, you still want to follow up. You still want to make sure she's okay. Why did she fall? You know, was she outside? Was she doing something she shouldn't? Was whatever. Following up is also very important after any care transitions. And you want to make sure that home health and community-based services are coordinated for that patient. And I know the hospitals do that a lot anyway before discharge, but when you're doing the CCM services, that is all stuff that can be billed for. All that time spent doing that with those patients can be billed for, okay? But as it says down here, providing these services must be tracked. So whether it's an electronic health record or manually tracking it. Don't just delete emails, you know, make sure you know the day and the time, and, you know, your very type A personality care coordinator will monitor all that. So when you're billing for these services, the very first one, the comprehensive assessment and care plan, this is your face-to-face in-office visit, okay? This is where you're going to enroll a patient. This is where you're going to get that comprehensive assessment so that you can do the care plan and explanation of the services. And this is an add-on code to a standard E&M code. So you can add that on, like I said, to your other billing, if they're in there for, I'm sorry, a wellness visit. This can go along with that, okay? So again, this would be for the initial, and this is in red here, in office. Now, initially, this was the only code that they were paying for. When CCM first started in 2015, this was the only one. Now we have 5 additional ones. So then we've got this standard CCM, which is 20 minutes of care management outside of office visits. And this is performed by clinical staff. So that's your team, your type A care team person. And they look at the care plan, it's regularly reviewed. So 20 minutes per month, at least, you can bill for, okay? Then you've got a non-complex add-on. So this is brand new because non-complex, an additional 20 minutes added on to this first CPT code. 99490 is your initial 20 minutes, and then they've added an additional 20 minutes of non-complex. And you can report that up to 2 times per month. So if you have a frequent flyer that is constantly calling into the clinic and, you know, wanting to know this and asking that and having trouble with this and needs that, you have to keep track of those minutes, because if you're only billing this, but you're spending 45 minutes per month with the patient, you're losing 20 minutes of reimbursement right here. So just keep that in mind. I'm sorry, my phone is ringing. Again, we have billing for CCM services. And another one, 60 minutes of clinical staff. So this is 60 plus. So you can use the, let me go back one slide. You can use this 99490 and this 99439 twice during the month. That gets you to 60 minutes. Or once you get past that 60-minute mark, you've got complex CCM and complex add-on. That's an additional 30 minutes spent after this 60 minutes. Now 90 minutes is quite a bit of time throughout the month, but I don't know, there are some patients who require a lot of hand-holding. Okay. And then we've got physician provided time, and this is 99491. This is personally provided by the physician or the nurse practitioner or the PA or whoever it happens to be. So this is professional services. This would be time spent by your care coordinator in the office, which could be a nurse. Okay, only one physician or qualified healthcare professional, nurse practitioner or PA, can bill. So the services by the clinical staff person or your care team member must be billed under one of the following. So like we said before, an independent case manager that does not work with a physician, that's just managing care, they cannot bill for this services. It has to be billed under one of these professionals. Okay. So Medicare continues to support and encourage chronic care management in practices to lower costs and decrease hospitalization, because in the short period of time, they've seen that it's needed and that it is working. But practices that have implemented CCM programs have reported frustrations, including having more work to do than what's being reimbursed, and challenges with care plan creation and content. Again, these are probably practices that said, hey, this looks good, let's try this. You can't try it. You have to plan it and you have to make it work. So it's not just a trial and error kind of program. And I know I kind of beat that one to a pulp earlier, but you do have to plan or it's not going to work. And it's kind of scary here because in 2017, only 9,000 out of 400,000 eligible providers billed for the services. Wow, that's a fraction. That's next to nothing. So CCM services, it has to be value-based care, value-based payment, value-based programming. That's all that's out there right now. And we have to look at our patients, patient-centered care, and CCM services can work. It does work, but again, you have to be documenting. You have to have all those key pieces. I would suggest checklists. I'm a checklist kind of person, so that I can make sure I've got everything that I need. Review the care plans, review all those care plan templates that are out there and make one that works for you. Don't use a canned template because that template specifically works for whoever made it. So look for something that's going to work for you. Look for something that's going to work for your patients. But that must be done. That is not something that we can not have before the patient is, you enroll them, you get that care plan made. It's not something that can be done weeks later. It has to be done right away. So here's your strategic mistakes. Not planning before starting. Some people start, and like I said, it just kind of collapses on them. If you have someone that is not capturing these patient interactions and documenting them, it's going to fail. You're not going to get reimbursed for all those interactions, and you might be having 60 minutes a month with certain patients. If it's not documented properly, you're not going to get reimbursed. Not capturing the minimum care plan requirements. And there are, like I said, checklists, and check the references at the end of this program. Lots of stuff in there. CMS has lots of information out there. They even have a little booklet on chronic care management, which I suggest everyone read before even deciding if you want to do it. That is definitely in the references at the end. You have to embrace the program. If it's a physician's office that's going to do it, the whole team has to do it. Because if Mrs. So-and-so is calling and Lisa's out on lunch and somebody else is taking the message or talking with this person, the patient, then if it's missed, the documentation on it is missed and it's not documented, guess what? You're not going to get paid for it and you're going to lose reimbursement. And I do suggest an electronic health record, only because it just is going to make life easier because of the frequent contacts with the patients that you're going to have throughout the month. But, you know, by all means, if you have to keep it on paper, then make sure that whoever's documenting is documenting appropriately. Just a little tidbit of information. CMS is starting to kind of look at what's being billed, how it's being billed. This is a comparative billing report, and this was sent out to all the physicians who are billing for CCM services. Unfortunately, we can't get that because it's not public information, but they are looking at the spending. And that only means that if there's a lot of time being spent, maybe there'll be more CPT codes coming out for the different types of services that are being provided. But this just kind of helps physicians know what they're spending, what their peers are spending, what the billing is. So it's just a helpful thing for the physicians who are already in the program. Transitional care management is another CPT code that can be billed, and it may be delivered during overlapping calendar periods. Just make sure that the services that you're delivering under transitional care management and CCM, that you're not billing for both and using all the same information. I kind of said that earlier. Make sure that your transitional care management is billed, and then you start your documentation for your CCM management. So just make sure that those two items are separated and the documentation is clearly delineated in your medical record. This way you're not getting accused of double dipping. Share your care documents with other providers, and help the resident or patient manage transitions between and among healthcare providers and settings. When they come home from the skilled nursing facility, if they were in for rehab, they had now they're home, they're doing okay, you want to check on them. You can bill for those under CCM. So if you have the program in your practice, then take advantage of everything that you're allowed to bill for. Excuse me. I had to take a sip of water, I apologize. Here's just a couple of examples. They're very basic, but it's stuff that happens every day. And these are things that you can take advantage of. So for the first one, a patient was confused when they called. They called for their monthly update. Patient a little confused, got her in. She may have wound up in the hospital. They prevented the urinary tract infection. So, excuse me, I'm so sorry. The other one was the patient-assisted living, blood glucose reading. Now, clinical staff, sorry, apologize, kind of did some investigating. So because they were investigating, they can bill for that time because they had to go back and forth with the facility. And then they found out that, he ate a little bit too much cake, a little bit too much party time there. So with that being said, they may have shipped this person out to the hospital, if the blood glucose level kept going up. So they were able to stop that. So that prevented an emergency room visit. And that was because they called. So the CCM program, I truly believe this can work. but again, you must plan. Again, it will enhance physician practice with increased reimbursements, and patients receive exceptional patient-centered care. It's a win-win for both sides. Now, again, the physician practice, the increased reimbursements, we're not talking about hundreds of dollars, per call, but we're talking about potentially paying and receiving additional reimbursement for that additional team member, depending on how many patients are signed up. We're not talking about 5, we're talking about hundreds in a physician practice that potentially can be enrolled in the program. And when you're talking about hundreds that are potentially calling into the office during the month, that's quite a bit of money to come in. So again, I think I've exceeded my time. I apologize. Our learning objectives, hopefully you feel like you've come away with this information. I appreciate you listening. Again, please email me. I'm sorry that there's not a lot of time for questions. I will take questions via email. Just send them on. I'll be happy to answer and send you any information that you might need. Here's your references and resources. Lots of stuff out there. Dig, 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 find what works for you and jump in with both feet, but be prepared.
Thank you, Lisa. Quick question. Do you have a concise checklist of things that should be considered prior to implementing a CCM program?
Yes, I do. I think it's in the, let me go back. Let me see which one it is. Here's the care plan template right there. I do have one. Just send me an email. Let me get to my email here so you can see. Here I am, lisa.pando@kerrydunningllc.com. Send me an email with that request and I will attach it to the email and send it out.
Okay, thank you. Thank you. We are out of time for today. As Lisa said, she's willing to ask questions afterwards. And we hope that based on your feedback from past evaluations, that this provided some clarity around management and the program and requirements and some of the billing aspects. Again, keep your questions coming to us and we will get answers back to you. And Lisa, we really appreciate your time. We appreciate the list of resources that you provided at the end and have really given individuals a lot of food for thought in implementing this type of program. So thank you so much. Have a wonderful day and stay safe, everyone. Bye-bye.